Dr. Neil Bordloy to conduct this session. He needs no introduction. He's the face of the Northeastern region in cardiology. He's the managing director in HOD of Department of Cardiology, Excel Care Hospital, and he's the president of Northeast Cardiology Society of India, Northeast Chapter. So I request Dr. Neil Bordloy to conduct this session, please. Thank you.
Thank you, Dr. Farin. And after the great quiz contest, we are coming to the very important session, the heart failure session. And the chairpersons are all of them here. Madhuvira Baido Asenegi, Professor MP Das, Manohar. Is Dr. Manohar there?
Yes, sir. Good evening.
Oh, good evening. And Dr. N.K. Bhattacharya, Dada Ase?
Yes.
Dada Ase apni? I think Professor MP Das, she will join us in due course. Farin, you can ask, you can make a few calls and ask them to join.
Yes, yes, definitely.
I think we'll not waste time. I'm handing over the session to our chairpersons who are present, Manohar and I think Nirmalda also there. So I hand over the session to you to introduce the first speaker and the talk.
Yeah, can I get the slides, sir? Yeah. Good evening, everyone. And first presenter is Dr. Pranav Dekka. He is a senior interventional cardiologist. He has done his DM from AIMS, New Delhi. Presently, he is working as consultant interventional cardiologist in Narayana Super Specialty Hospital, Guwahati. With this, I welcome Dr. Pranav Dekka. Please deliver your lecture. Thank you.
May I also add that he's a extremely courageous and brave person also. Pranav?
Pranav, you unmute yourself.
Yeah.
Yeah, Pranav, you
Now
can
it is
start.
audible. Am I audible, Manohar?
Yes,
you're audible.
yes.
Okay. Then
Neil, I'm here. Neil. Hello, Neil.
Hello.
Nirmalda?
Yeah, I'm here. My video is giving little problem, but I'm here.
Yeah, no, I told you, Makalu Nirmalda is a Welcome, Nirmalda.
Okay, thank you.
So, Pranav, you can start your presentation. Unmute yourself. Unmute yourself.
Yeah.
Yeah. So you can do a share screening and start.
Okay. Thank you, Nilda, Manohar.
Pranav, talk is 12 minutes with just discussion, 3 minutes discussion.
Okay.
So you can just say next. I'll go through the presentation.
Am I audible?
Yes,
Hello?
your
Yeah, you're
slides
audible.
are also visible. Please go ahead, Pranav.
Oh.
You just need to say next.
So we have a talk today on contemporary management of chronic heart failure. Today I'll briefly discuss this topic. First, let's have a look at the epidemiology of the chronic heart failure. As per clinical criteria, the prevalence of chronic heart failure is 1 to 2% all over the world. And males are more affected than females. And in 65 years above patient, the prevalence is 7%. And 50% of patients with left ventricular systolic dysfunction is asymptomatic. And heart failure with preserved ejection factor varies from 15 to 50%. And the incidence rate is 0.2 to 0.3%. And it increases with age. Now, around 62 million adults worldwide are estimated to living with a heart failure, and this number is expected to rise because of the increasing aging population, increased prevalence of various risk factors like diabetes, hypertension, and improved post-MI survival because of better management of acute coronary syndrome and STEMIs. Now, let's have a look at the natural history of this chronic heart failure. First, we start with a normal heart on the left side. After initial myocardial injury occurs, it may be SCS, it may be STEMI, then a patient may remain asymptomatic. throughout. And after a few months or the undefined period, the patient may develop acute decompensation of heart failure. Then patient himself may forget the acute event when he had suffered the event. And that event may be with pulmonary edema requiring emergency admission and ICU care. And usually patient survive that first decompensation of heart failure, and subsequently he remains stable on medical therapy. But after a few months or varied period, he again suffered a decompensation as shown in a deep, as shown it is a deep here. So again he recovered with treatment. Then again he may suffer. Now each decompensation is associated with a residual damage to the heart. So there is a progressive development of the symptoms, or progressive pump failure occurs with each decompensation. So, and with this recurrent decompensation, patient may finally develop end-stage heart failure and death after a few years. Now coming to the classification of heart failure, in ESC heart failure guideline of 2016, the heart failure has been divided into 3 groups. There is heart failure with preserved ejection fraction, heart failure with mid-range ejection fraction, and heart failure reduced ejection fraction. So heart failure reduced ejection fraction is defined by LVEF of less than 40% and with or without symptoms, and heart failure with mid-range ejection fraction is defined as EF of 40 to 49%. And heart failure of preserved ejection fraction is EF of around 50% with elevated level of natriuretic peptide and other clinical signs and symptoms. But subsequently, it has been reviewed, and this mid-range ejection fraction has been defined as mildly reduced ejection fraction. Heart failure with mildly emerging data, patient with heart failure ejection fraction in the mid-range between reduced and preserved, that is 41 to 50% may benefit from neurohormonal blanket like those with a lower ejection fraction. These are important differences based on patient sex, with women and with heart failure benefiting from neurohormonal blockade at higher ejection fraction than men. Recent data support defining heart failure with reduced ejection fraction as less than 40%, mildly reduced ejection fraction, and normal if ejection fraction is more than 55% for men and more than 60% for women. This is published in JAC, recently published. So prevalence, I have already covered this. So chronic heart failure is basically a devastating burden, because despite the introduction of the treatment, the mortality rate for patients with chronic heart failure is about 50% at 5 years post-diagnosis. Now recently, there is a position statement has been published in European Journal of Heart Failure regarding the patient profiling in heart failure for tailoring the medical therapy. This is basically a consensus document which is followed by the ESC guideline of 2021. As per this consensus panel, it has been noted that despite guideline recommendation and available evidence, implementation of the treatment in heart failure is poor, and majority of patients are not prescribed drugs at target doses that have been proven to positively impact morbidity and mortality. Among others, tolerability issues related to low BP, heart rate, impaired renal function, or hyperkalemia are responsible. CKD plays an important role as it affects up to 50% of patients with heart failure. Also, dynamic changes in the eGFR may occur during the course of heart failure, resulting in an inappropriate dose reduction or even discontinuation of the decongestive or neurohumoral modulating therapy in clinical practice. So, as patients with heart failure are very rarely naive to pharmacological therapies, the challenge is to adequately prioritize or select the most appropriate up titration schedule according to the patient profile. The consensus document identified 9 patient profiles that may be relevant for treatment implementation in heart failure patients with a reduced ejection fraction. This profile takes into account the heart rate, it may be less than 60 or more than 70, the presence of atrial fibrillation, symptomatic low BP, eGFR of less than 30 or more than 30 per square body surface area, or hyperkalemia. The pre-discharge patient frequently still congestive also addressed. Now, personalized approach according to the patient profile. Adjusting the guideline directed medical therapy to the patient profile may allow to achieve a better and more comprehensive therapy for each individual patient.
Sir, I am presenting your presentation, not at your end. You need to follow the Zoom and tell me next. Right now, I'm on patient profiling in heart failure.
Okay, that is our next slide. the core of heart failure treatment should be started in all patients with heart failure. So that is the core is at the center. This is dark level shown that SGLT inhibitors, beta blocker, SC inhibitor or ARB or ARNI or MRA or diuretic must be given in all patients with heart failure. Apart from that, depending on the heart rate, other therapy need to be added or discontinued. Depending on the heart rate and BP, as well as presence or absence of atrial fibrillation, presence or absence of CKD, hyperkalemia, or presence or absence of congestion. Next slide, please. Now coming to the tailoring of medical, according to some patient characteristic, like BP, heart rate, as I already told, some drugs may be reduced or some they may be discontinued or added. The black drug that is at the center of this diagram, this drug has to be given to all patients, and red drugs that should be reduced or discontinued. Blue drug that should be added according to physical condition. Now this slide shows a common comorbidity seen in heart failure patient and impact on the use of guideline directed medical therapy. Like comorbidity like coronary artery disease, if the patient have a CAD and angina, then beta blockers and evaporating therapy may help in control symptoms of CAD as well as in heart failure symptoms. Then next, diabetes. If patient is diabetic, then GDMT has to be started, has shown similar benefit in the diabetic patient. Suppose patient have a chronic obstructive lung disease or asthma, then it may be a relative contraindication to the beta blocker. Starting with low doses of cardioselective beta blocker may allow easy use. And beta blocker should be given in patient with COPD and heart failure. Then next, coming to the comorbidity is depression. GDMT must be started in patient with depression, but depression is associated with low adherence to the medication, so compliance reduces if depression is present. Suppose if the patient have a erectile dysfunction, then thiazide, spironolactone, and beta blockers may aggravate the erectile dysfunction. But in this regard, nebivolol is quite helpful, and this may reduce the erectile dysfunction. So in this condition, nebivolol is preferred if the patient have a erectile dysfunction. Suppose patient have a iron deficiency.
Sorry to intervene, please. Your slides are not telling with your presentation. Can you share your slide from your end, one of that? You share your slide because your presentation is not telling with the whatever they are showing. So please share from your side.
Okay, okay, sorry for this.
That's okay, one of that. Please share yours.
Share screen is not coming here. Actually,
can somebody help him to share his screen?
So there will be a green button on Zoom.
Green button on Zoom, okay. Yeah. I got it. Yes. 1 second. I'm very
share screen to provide one of the.
Yeah. I have pressed the share screen.
Then you have to select the presentation.
Yeah. Now it is coming?
Yes.
Yeah, good.
Yes, good.
Okay,
Good to
thank
go.
you.
Please go.
This is the comorbidity slide with heart failure. Next, coming to the iron deficiency, anemia, and chronic kidney dysfunction. So, SC inhibitor, ARB, or ARNI, MRA may have some limitation in use in patient with CKD or anemia. So, diuretics may need higher doses to be effective. If the patient have a cardiac cachexia, then SC inhibitor, ARB, ARNI should be uptitrated carefully because of the orthostatic hypotension frequently seen in patient with heart failure with cachexia. Now, these are trials. This is a very congested slide actually showing various trials starting from VHAP to the galactic heart failure. Next, coming to the management of heart failure, reduce ejection fraction. So, to reduce mortality for all patients with heart failure, we need to give SC inhibitor or ARNI, then beta blocker, mineralocorticoid receptor antagonist, and SGLT2 inhibitors. To reduce heart failure hospitalization or mortality for selected patient, then in volume overloaded patient, diuretic need to be added. Apart from that, sinus rhythm with LVV, then more than 150 millisecond, then we need to consider for CRT or ICD, CRTP or CRTD or ICD. And there is another presentation for device therapy, so I'll not cover this. Going to the next slide. Now coming with the Emperor reduced heart trial, SGL2 inhibition with empagliflozin is effective in heart failure with reduced ejection fraction with or without diabetes. So primary endpoint was significantly reduced by 25%, and p-value is highly significant. And first secondary endpoint also reduced by 30%. Now next coming to the Vericiguat, this is a newer drug, and a Victoria trial has been recently published in NEJM with over 5,000 patients with reduced heart failure with NYHA class 2 to 4. With after worsening event, it has been added with recent heart failure decompensation. So it has been shown that Vericiguat reduces the recent heart failure, hospitalization, and cardiovascular death. And the annual number needed to reduce this CV death or fast hospitalization is 24. Now coming there to the next drug, that is omecamtiv mecarbil. This is recently, this trial, this is Galactic Heart Failure trial, is presented in SCC 2021. And this trial has been conducted in over 8,000 patients. And it is basically a myosin activator. It has been shown that this drug increases the cardiac contractility. And by doing so, it reduces the composite risk of fast heart failure or cardiovascular death in patients with heart failure. The effect is especially seen in patients with ejection fraction of less than 28%. Next, coming to the, let's have a look at the guideline. Now, diuretics are recommended in patients with congestion and heart failure in mid-range ejection fraction in order to alleviate symptoms and signs. As far as 2016 guideline for patients with non-valvular AF eligible for anticoagulation based on set to VAS score, NOACs, radar and warfarin should be considered for anticoagulation as NOACs as per 2016 guideline. But according to recent 2021 guidelines, these NOACs are recommended in preference to vitamin K antagonists in patients with heart failure, except in those with moderate or severe mitral stenosis or mechanical prosthetic valves. So NOACs are recommended over VKs nowadays. So with this, I would like to thank you for patient hearing. Thank you for patient hearing. And this is the brief presentation of chronic heart failure. Thank you for giving me a chance to present this. Hello, am I audible?
Yeah, thank you, Pranabda, for your beautiful presentation.
Okay, thank you, Manohar.
If Nilda, you would like to ask any question, or we'll go to next presentation?
I think Madhumita Baidu is here if she wants to say something, and she can introduce the next speaker. Madhumita Baidu is here, I think. Baidu?
Good evening, ma'am. Welcome to our Cardiology Society.
Baidu is being extra shy. She's not.
Hello, Neil. Hello, Neil.
Ah.
Neil, can you hear me? This is Sangeet Datta.
Oh, Sangeeta.
Yes.
Good evening. Good evening.
Good evening. Tell me
Good
something.
evening.
Tell me
Manohar here.
something. Yes, tell me something. Why aren't you giving DOACs for those who have mitral stenosis?
Wax.
Yes,
Actually,
not.
as per trial criteria, sir, as per trial criteria, this has been not included in rheumatic, moderate to severe mitral stenosis. And even in prosthetic heart valve also, this has not been found to reduce the cardiovascular event. Like in Dabigatran has been tried in patient with prosthetic heart valve. So there's no significant reduction in the events. There is thrombotic event with NOACs. That's why it is usually not recommended in moderate to severe mitral stenosis or in patient with prosthetic heart valve. In prosthetic heart valve, it is still vitamin K antagonist is considered as ideal for reducing the thrombotic event.
And severe mitral stenosis also, you are using this VKA?
Yes.
As he said, the trials actually they don't recommend giving in prosthetic valve and in severe, probably because the chances of thrombus and thromboembolism are very high in these. And when you increase the dose of NOACs to combat that, there is a risk of bleeding. So that is why they are not recommended.
But warfarin also will have, the other anticoagulants also will have risk of bleeding.
No, but the NOAC, the dose at which the NOACs are given for the other conditions, they do not have
Very
that high.
non-valvular, sir, the bleeding risk are quite low. It has been shown in the trials. That's why.
Or is it that you can monitor better with this VKA and you cannot, there's no monitoring for NOACs? That's the problem?
No, that is not the problem.
That is not the thing, sir. That's
That is
because
the
of-
advantage actually with NOACs. You don't need to go on monitoring.
So then you don't know if it is you're overshooting, no?
Sangeeta, that's a different. This is a heart failure
Monitoring.
session. Sangeeta,
Okay,
this is a
fine.
heart.
Carry on. No.
Yeah.
Go on to the next session.
Can I answer this, sir?
Yeah, sure.
So actually, NOAC
We are already
is,
going behind time actually.
only depend upon the etiology of the condition. See, rheumatic heart disease and this severely mitral stenosis, the etiology is different. So in presence of continuous inflammatory process, so you cannot give the NOAC in inflammatory processes. So because of that, NOAC is not recommended even in prosthetic valve as well as where the continuous inflammation and deformity is there. It is only for the non-valvular fibrillation, atrial
Okay, I
fibrillation.
think whenever we are going behind time, so let us stick
Yeah,
to the
please.
agenda.
Please go ahead.
So I request Nirmalda to then introduce the next speaker and the topic. Nirmalda. Nirmalda, please unmute yourself.
Okay, am I audible now?
Yeah.
Now, I think next topic is heart failure with preserved ejection fraction. It will be presented by Dr. Chandan Mudok. He is a very renowned cardiologist, budding cardiologist, energetic cardiologist, and we definitely will be getting input from him, who will help us in this.
Thank you, sir. Thank you so much.
Are you feeling well? You are as of now you are suffering from COVID and yet you have agreed to give the talk. Thank you so much.
But today my antigen test came negative. So can I go to Novotel now?
But now you are not welcome.
Okay, continue.
Am I audible? Hello?
You are audible.
And
Yes.
my slides are visible?
Yeah, it's visible. Please go ahead.
Good evening, respected seniors, my dear colleagues. First of all, I thank Northeast CSI and all the organizing committee members for giving me the opportunity to present this topic in front of you all. My topic is heart failure with preserved ejection fraction, its diagnosis and management. As we all know that heart failure is a complex clinical syndrome that results from structural and functional impairment of either left ventricular filling or ejection of blood. So although similar clinically, the heart failure with preserved EF is different from reduced ejection fraction in several ways. For example, most of the patients are elderly, 85% of the patients are hypertensive, and female population is more common in this group. And also the structural abnormality like concentric remodeling of left ventricle is more common in preserved ejection fraction. But the coronary artery disease are more commonly seen in heart failure with reduced ejection fraction. Also, the therapies which have been proven mortality and morbidity benefit in randomized controlled trials has failed to show benefit in patients with heart failure with preserved ejection fraction. So this is a large area of unmet need, and it affects about 5% of the general population aged more than 60 years, and it also accounts for more than 50% of the hospitalization for heart failure. Also, the randomized control trials have shown that the mortality of heart failure with preserved ejection fraction is lower than those of reduced ejection fraction. But the epidemiology studies have shown that heart failure with preserved EF have got a devastating 5-year mortality of approximately 60% and costly morbidity in terms of 6 months hospitalization rate of about 50%. Coming to basic pathophysiology, basically diastolic dysfunction is the main cause of heart failure in heart failure with preserved ejection fraction. And the underlying mechanism is mainly left ventricular relaxation abnormality. Then there is increased stiffness of the left ventricle. So there is reduced compliance of the left ventricle. There is a structural remodeling and altered geometry of the left atrium and left ventricle. Changes in the compliance in left ventricle, systemic, pulmonary vascular system. Then skeletal muscle and endothelial dysfunction is there. And all these things are thought to be primarily occur due to some of the pro-inflammatory and pro-fibrotic cytokines released by all the antecedent and comorbid diseases which are very common in patients with heart failure and preserved ejection fraction. For example, hypertension, diabetes mellitus, insulin resistance, overweight, obesity, coronary artery disease, hyperlipidemia, aging, anemia, and CKD. These all lead to increased hemodynamic load and metabolic load, which in turn increases the sympathetic activation, and there is parasympathetic withdrawal, which again lead to renin, angiotensin, aldosterone system activation and release of interleukin-1, 6, TNF alpha, soluble ST2, then pentraxin 3, galectin 3, and TIMP1. These mediators increases the circulating hematopoietic progenitor cell, and also it affects the reactive oxygen species and leads to endothelial dysfunction because of reduced nitric oxide synthesis. Again, this leads to lower amount of soluble gonal cyclase. So there is reduced cyclic GMP and protein kinase Z activities lowered. That leads to abnormality of the titin phosphorylation and cardiomyocyte dysfunction due to abnormality of the various ion channels. There is calcium handling, and the titin isoform change from less compliant isoform, that is N2B isoform of titin. And also in the extracellular matrix, there is changes in the hemostasis. So there is more formation of fibrillar collagen, which is more stiff. So due to activation of the transformic growth factor beta, which converts fibroblast to myofibroblast, and then formation of collagen. So all these factors of changes in extracellular matrix and cardiomyocyte dysfunction leads to diastolic dysfunction. So coming to some of the secondary causes or the heart failure with preserved ejection fraction mimics, we all know that hypertrophic cardiomyopathy, restrictive cardiomyopathy, valvular heart disease, constrictive pericarditis, high output heart failure, and some other conditions like ischemic cardiomyopathy or myocarditis may lead to clinical pictures similar to heart failure with preserved ejection fraction. Now let us go to the diagnostic process. Recently, in the August 2021, ESC guideline has laid down very simple diagnostic approach that starts with a clinical assessment of pretest probability. First, take the sign and symptoms of heart failure. If they are present, then we should look for the ejection fraction. If ejection fraction is more than or equal to 50%, then we should look for the objective evidence of cardiac structural or functional abnormality which are consistent with presence with LV diastolic dysfunction, raised LV filling pressure, including raised natriuretic peptide. And stress testing and invasive measurement of elevated LA and LV pressure are needed only in cases where there is uncertainty. So these are the measures and cutoff points described by European Society of Cardiology. We will be discussing in the diagnostic criteria. So diagnostic workup starts with clinical assessment followed by ECG to look for atrial fibrillation, left ventricular hypertrophy, standard echocardiography to look for the ejection fraction and exclude significant valvopathies. Then two scoring system is there. One is heart failure association PEFF score, and another is H2 FPEF score. H2 FPEF score is a very simplified score. H2 stands for heavy, that means BMI more than 30 kg per meter square. That carries 2 points. Hypertension requiring more than or equal to 2 drugs carries 1 point. F stands for atrial fibrillation, which carries 3 points. That may be paroxysmal or persistent atrial fibrillation. P carries pulmonary hypertension, that means pulmonary artery systolic pressure more than 35 millimeter of mercury on echo, carries 1 point. Then elderly means age more than 60 years, 1 point. And F for filling pressure means E by E dash ratio on tissue Doppler imaging more than 9, carries 1 point. Similarly, Heart Failure Association of ESC has provided one scoring system. One is the comprehensive echocardiography that has got 2 domains, functional domain and morphologic domain. Functional domain contains minor criteria, that means 1 point for average E by E dash ratio if it is more than 9 and less than 14, and global longitudinal shortening if it is less than 16%. Similarly, if E by E dash ratio is more than 15, or E in the septal, that is septal E dash less than 7 centimeter per second, or lateral E dash less than 10 centimeter per second, and average E by E dash more than 15, TR peak velocity more than 2.8 meter per second, and pulmonary artery systolic pressure more than 35, then this becomes major criteria and it carries 2 points. Similarly, anti-pro-BNP criteria, major criteria is 2 points if anti-pro-BNP is more than 220 for sinus rhythm patients and more than 660 for atrial fibrillation, BNP more than 80 and 240 for sinus rhythm and atrial fibrillation respectively. And minor criteria is anti-pro-BNP 125 to 220 and 375 to 660, BNP 35 to 80 and 105 to 240. So heart failure with preserved ejection fraction probability can be achieved by these 2 type of scoring system. If the score is from 2 to 5 in H2P, H2FPPF score, then it is intermediate probability, and in HFA PEFF score, if it is 2 to 4, then it is intermediate. So if the score is more than 5, more than or equal to 5, then it is high probability of, and the heart failure or preserved ejection fraction diagnosis is confirmed. If the score is less than or equal to 1, then the heart failure with preserved ejection fraction is excluded. And for those intermediate probability patients, we need advanced workup of non-invasive stress testing. If with exercise the E by E dash value is more than 15 or TR velocity increases to more than 2.4, or in then it is a diagnostic. Or if invasively we can see the left ventricular endospheric pressure of more than 16 or pulmonary capillary pressure of more than 15, and with exercise if it is more than 25, then the diagnosis is confirmed. After confirmation of the diagnosis, if we suspect some secondary heart failure, secondary causes, we should advise some more investigations like cardiac MRI, cardiac biopsy, CT scan, etc. So coming to management, none of the last randomized control trials conducted so far has achieved their primary endpoint. This include PEP-CSF for pre-endopial, charm preserved for candesartan, eye preserved for irbesartan, topcat for spironolactone, dig preserved for digoxin, and Paragon-ASAP trials sacubitril valsartan. Although hospitalization for heart failure was reduced by candesartan and spironolactone, but as the studies could not achieve primary endpoint, so these are only hypothesis generating findings only. Although nebivolol significantly reduced combined primary endpoint of all-cause mortality or cardiovascular hospital admission in seniors trial, this trial included only 15% with heart failure with ejection fraction more than 50%. Trials targeting the nitric oxide cyclic guanosine monophosphate pathway have also failed to improve exercise capacity, quality of life in this group of patients. For example, NEAT HFPEF for isosorbate mononitrate. Then inhaled organic nitrate was used by INDI HFPEF. Then Vidiciguat was used by Vitality HFPEF, and capacity heart failure PEF used Praliciguat. So all these trials failed. So even FDA has approved sacubitril valsartan and spironolactone in those patients with LVEF less than normal. That means for patients of mildly reduced EF or preserved ejection fraction patients, because this is based on the subgroup analysis from Paragon-ASAP study, which showed a reduction in heart failure hospitalization in those with EF less than 57%, and also meta-analysis of Paradigm heart failure and Paragon-ASAP studies showing reduction of CV death and hospitalization in those patients with EF below normal range. Regarding spironolactone, the subgroup of individuals in the TopCat study recruited from America showed significant reduction in primary endpoint of CV death and hospitalization, and subsequent post-hoc analysis also showed that EF showed that significant reduction in outcome in those with EF less than 55%. So coming to this is the latest trial published in 27th August in NEJM. This is the Emperor Preserve trial. They have the total number of patients enrolled were 5,988. They randomized in a 1:1 fashion to either empagliflozin 10 mg or missing placebo. And the trial was stratified according to the geographic area, diabetes status, eGFR, and LV ejection fraction of either less than 50 or more than 50%. Duration of follow-up was 26.2 months median. Mean age of the patient was 72 years and 45% were female. Inclusion criteria was all the adults more than 18 years with chronic heart failure, NYC class 2 or more. Preserved ejection fraction was defined as more than 40%. Then anti-proBNP more than 300 and 900 in sinus rhythm or AF respectively. Structural heart disease confirmed within 6 months, or that is documented heart failure hospitalization within 12 months, and stable doses of diuretic if they are on diuretic. And the patients with acute coronary syndrome, stroke, transient ischemic attack within 90 days, then listed for heart transplantation or heart transplantation recipient, acute decompensated heart failure, systolic BP more than 180 or less than 100, liver or kidney disease, eGFR less than 20, and current or prior use of sodium glucose co-transporter, that is empagliflozin or other gliflozin, were excluded from the trial. And most of the patients had mean LVEF was 54.3%, and 51% had atrial fibrillation, and 49% had type 2 diabetes mellitus. So coming to the result, the primary outcome, that is a composite of cardiovascular death or heart failure hospitalization, was significantly reduced in the Emperor Preserve trial. So there is significant reduction of heart failure hospitalization. It was seen in 8.6% in empagliflozin group versus 11.8% in placebo, and significant reduction of heart failure hospitalization and cardiovascular death. But the cardiovascular death alone was not significantly reduced. And regarding the secondary outcome of the hospitalization, total hospitalization was reduced, and changed in mean eGFR slope per year was reduced significantly. But composite of renal outcome, all-cause mortality, new onset diabetes mellitus showed no difference between the two groups. So SGLT2 inhibition with empagliflozin led to a 21% relative risk reduction in composite of cardiovascular death or hospitalization or heart failure, which is mainly related to 29% lower risk of hospitalization for heart failure with empagliflozin. In contrast with findings in earlier trials of candicertan, spironolactone, and sacubitril valsartan, the results favored empagliflozin with hazard ratio less than 1 for primary outcome in each of the ejection fraction subgroup. The benefit was consistent across pre-specified ejection fraction subgroups and was seen in patients with or without diabetes, among patients with symptomatically stable heart failure with EF more than 40%. The benefit is primarily driven by the reduction in hospitalization only, not mortality. There was also a benefit in eGFR, but not in renal outcome per se. So to summarize, the empagliflozin is the first and only therapy achieving primary endpoint in randomized control trial. In the absence of recommendation regarding the disease-modifying therapies, treatment should be aimed at reducing symptoms of peripheral and pulmonary venous congestion with fluid and sodium restriction to less than 2 grams per day, and judicious use of diuretics. Tube diuretics are preferred, although thiazide diuretics can be used as a part of management of hypertension. And non-pharmacological intervention, for example, reducing body weight in obese patients, lifestyle intervention, and increasing exercise may further improve the symptoms and exercise capacity, and should there be considered in appropriate patients. It is important to identify and treat antecedent comorbid disease and underlying etiology, because most of the patients are hypertensive, diabetic, obese. They may have atrial fibrillation and coronary artery disease, so we should manage accordingly. So to conclude, although heart failure with preserved ejection fraction pathophysiological mechanism are becoming clearer over the years, there is still no effective treatment showing clear mortality benefit. Numerous trials are underway for future successful therapies. We should not forget the importance of preventive strategies and to aggressively address associated comorbidities. To finish with the words of Samuel Beckett, ever tried, ever failed, no matter, try again, fail better. Thank you.
Thank you, Chandan, for sticking to the time, and also thank you for giving us the emperor preserved findings also. The only medicine which has been actually shown to have some benefit in this condition. So we are short of time, so if the chairpersons want to say one or two remarks, it's okay. Otherwise, we'll go off to the next presentation. Request Madhumita Baido to come in, please. Madhumita Baido, you're muted.
I'm sorry, I had some technical hitches. I joined in late. Yes, it's been a very enlightening talk, and I'm sure everyone has been benefited out of what you spoke. And I don't really have any questions. Maybe we can go on to the next subject.
Thank you.
Baido, you can introduce the next topic and the speaker, Dr. Indra Kaladipati.
Okay, Indra Kaladipati, I'm sure doesn't need much of an introduction to this audience. He is a renowned cardiologist, now practicing in, he's a consultant cardiologist now with Downtown Hospital. And he is well known in the field of cardiology to people in Assam and all over the northeastern states. And over to him for the next subject.
Yeah, thank you, Baido. Probably I'll share my slides. The technical, can you help? Probably have to stop sharing.
You have to just press this. Share.
Okay, no, okay. So thank you. I think all scholars of cardiology from our regions are here, and thank you Medical College and Northeast CSF for the opportunity. Easy, full screen. Okay. So my topic, obviously, when we talk about viability, it's mostly in a setting of heart failure, low ejection fraction, by definition less than 40%, and many of them have multivessel CRE. Now, a couple of important points. This is a short presentation. Obviously, assessment all over familiar, may not be available the facilities, but in terms of prognosis, we know. But I think more interesting in recent times, what is the importance of viability? If we do an investigation which is costly, what is the importance in terms of, and probably more important to the patients. So if we have viability or no viability, does it make any difference in terms of going for surgery or medical therapy, knowing that we have much more better medical therapy at recent times, including a couple of medicines that already been discussed, like hernia and SGL2. And on the reverse side, does no viability means is a dead end and patients will not benefit revascularization. And these are some of the important things. We know that is not an easy answer, and we'll couple try to address towards the end of my presentations. So when we talk about dysfunction, low ejection fraction, obviously somebody has scarred myocardium, it's a medical therapy, and personally we have much more to offer in terms of medical therapy. Viable, again, it may be hibernations, which is more of an insidious process, chronic ischemia leading to myocardial dysfunctions, which are going to recover after revascularizations. And revascularization means mostly is a case of coronary bypass surgery in a case of low ejection fraction. And stunning is a in terms of acute ischemia, although these are sometimes overlapping terms and one can lead to the other. In terms of methods that we have, obviously the gold standard is once we assess viability and we do revascularization like a bypass surgery and it recovers, then obviously that is accurate. But in terms of pre-test, before going for a procedure, there are tests available, and PET scans, PET, echocardiography, and cardiac MR and CT scans is new modality. CT has some of the recent developments, probably will not discuss because a very recent development in the field of viability assessments. In terms of principle, you can see these are the modalities look into different aspects of viability. Like in PET scan, they look at preserved metabolic activity. They have hypoperfusions, they are dysfunctional, but they have preserved metabolic activity like the preservation of glucose uptake, which is assessed by PET scan. MRI and SPEC look at this membrane integrity because if the membrane is intact, they can uptake some of the tracers that are used in SPEC and also in MRI. And whether in echocardiography, which you look for in stress-induced myocardial dysfunctions, which recover, this is a contractile reserve. And also the MR has advantage of assessing the myocardial scar, which is unique compared to other modalities. And obviously CT scans look for hyper enhancements. That's we're not discussing because they're very recent things. So just few of the important points to pick up from the investigation. PET scan, we know, is not available, but then is one of the ideal test. And we look at the disbalance between the perfusions, which are reduced, but the metabolism is preserved, at least at rest. And some of the images you can see that here, where the mismatch of perfusion and the viability is glucose uptake, which is preserved. That means the myocardial segments are viable. And these are continuous variable. And the more important is that the amount of dysfunctional, but which are preserved viability. And in either some beyond certain segments, beyond certain percentages, the benefit of revascularization probably will be present. PET has disadvantages, and I think to us obviously not available most of the places. But this is quantitative. It is better penetrations and obviously better imaging in terms compared to SPEC. But unlike MRI, you cannot differentiate between subendocardial or subepicardial, or even the degree of scar the myocardial segments. But look at the studies of PET scan. These are old studies. These numbers of patients are small. And you can see here that the ejection fraction is a range of 30 to 40. And if you look at the segmental recovery after bypass surgery, you can see the sensitivity and specificity is in the range of 70s and specificity in the range of 80s. So 80% sensitivity and specificity in the range of 73%, which are in the older generation trial. The second modality, which are I think available more frequently compared to PET scan, is SPEC, myocardial perfusion imaging, and thallium is one of the things commonly used, and CSTMV is not a good agent for myocardial viability. Principle already have said that because of it, look at the integrity of the cellular membrane. So thallium is taken up by sodium, potassium, ATPase. If it is present, that means the myocardium is viable. And these are the familiar images. We know we have to do short axis and horizontal and vertical long axis. And normally, if you give thallium and due to myocardium which are viable, they will have increased redistribution beyond certain hours, 3 to 4 hours, or even as late as 24 hours. So that means if these redistributions, late myocardial images shows preserve integrity by delayed clearing from the myocardial segment, that is, they are viable. As you can see here is that in the late images, the myocardial integrity is preserved by showing the hyperenhancements by thallium scans. If we look at the results, again, these are older studies. Number of patients are small in individual studies. But look at the predictable in terms of segmental recovery or improvement of the myocardial functions after surgery. Sensitivity and specificity is not very specific, 54 only in general, overall median, but the sensitivity is very high compared to PET. So SPEC have some disadvantages. Obviously, not available in most of the places. It is attenuation, especially in the inferior segments, and like PET scan, also it cannot differentiate epicardial from endocardial viability. Echo, I think the most commonly used is available, may not be used that much, but it certainly is available. And the hallmark of echocardiography is obviously stress-induced contractile reserve and the typical biphasic response where dysfunctional myocardium, which have improvement of contraction at low dose dovitamin and which again become dysfunctional at high dose, is a hallmark of viability. Other parameters are not very specific and sensitive, but are useful because they're very easy to measure, like LV and diastolic wall thickness. If it is very less than 6 millimeters, it may not be accurate, but is one of the indicator of having actually myocardial scar. On the other hand, if the LV is too much dilated, like LV more than systolic volume is more than 130 ml. These are the patients who probably may not recover after surgery. And tissue Doppler is also very exciting, and but not many data in terms of prospective studies. One of the examples in terms of viability, the biphasic response, you can see that the mid-inferior segments at low dose, the myocardial segments do recover compared to at rest images. And if we do high dose dovitamin more than 10, then again become dysfunctional, because at a very high dose of dovitamin, the myocardial segments, in that segments, the blood flow is not good enough to maintain contractility. If we see the predictive for in terms of recovery of myocardial functions after the surgery, you can see it is relatively highly specific compared to SPEC images and sensitivity in the range of 84%. Stress echo have limitations that we know. I think that is one of the limitations which are available. Is a poor acoustic window, and it is to a certain extent is more subjective compared to other images. But we look at some of the studies which have these are old studies before 2000s which have looked into the recovery of, these are not clinical endpoint, these are endpoint in terms of the imaging and then subsequent myocardial recovery after surgery. The retrospective studies, you can see the sensitivity and specificity of different in the range of 80s and 50 to 70s. So these are some limitations, but cardiac MRI is a new, comparatively relatively new modality, and it has certain advantages in terms of diagnosis. One is LV and actually wall thickness less than 5.5 is not a very specific, but it's one of the marker of having a scar. So if it is too thin, this may be scar. An inotropic reserve like dopamine stress echo, and also it also gives myocardial scar extent by late gadolinium enhancements. So somebody who for us with is enhancement with gadolinium, that means that is scar. So bright is dead, which is easy to pick up, and also the degree of scar, whether it's a transmural or like less than 25 or more than 75. So if the hypertension is more than 75, that means almost 2/3 is scarred. Then that probability of having recovery after surgery is less. If it's less than 25%, is recovery chances is good. Or any in between. So these are continuous variables. So degree of segments involved, number of segments involved, also the percentage of the transmural will give an idea how far the surgery will be helpful. This is one of the examples. You can see the anterior segments. The myocardium is thin, and actually you can see that almost 50% of the segments actually have late gadolinium enhancements, saying that these are probably scar more than 50% and probably not going to recover after surgery. So MRI's advantages. One of the advantages actually is it can have additional diagnosis, especially to differentiate from ischemic cardiomyopathy and non-ischemic and other inflammatory disease. So additional diagnosis, mechanical complications. But obviously CMR is not available, and it's a very high-end learning curve, and in our settings is not available. But one of the better modality nowadays in terms of assessment of viability. Now, if we look at some of the data in terms of, again, these are all data in the old data before 2000 in terms of recovery after surgery. You can see that these are meta-analysis. You can see those who have non-viable segments, their prognosis actually is worse. You can see that the events rate are higher, but then whether you do surgery or medical therapy, then there's no major differences. That means they have no non-viable segments, they can be sent for medical treatment. Whereas those who have viable segments, then actually they do worse with medical therapy. So this person do better with a coronary bypass surgery. But important thing is that these are the studies before 2000. And in those times, the medical therapy was not that good enough. There are no beta blocker I used, and including medicines like used nowadays, like MRA and ARNI and SGLT inhibitors are not used in this time, including beta blockers. So this data probably may not be relevant in our context where medical therapy is until is better. Now, what are the clinical outcome? Probably more important to the patients is that these data that we have discussed in terms of outcome, these are retrospective. Then medical therapy was not good enough, beta blocker are not used. These are before 2000. But we can pick up some of the important studies. This is widely quoted and one of the better studies in terms of assessment of myocardial viability in LV dysfunctions with multivessel disease. Here you can see that LV ejection fraction less than 35%, where that are randomized to medical therapy alone, medical therapy plus CABG, and all third arm was medical therapy plus CABG plus surgical ventricular reconstructions, and that most of us were aware of that. You can see that whether it's a medical therapy or CABG, the primary endpoint was total mortality. So you can see the primary event was not significant. Whether these patients who have ejection fraction less than 35, whether medical therapy or CABG, their actually event or primary endpoints are similar. Although there are differences in terms of secondary endpoint. So if the patient is sent for surgery, their probability of dying from cardiovascular disease is actually lower, although p-value is less 0.05. But if you add hospitalizations for cardiovascular cause plus CV mortality, then the benefit is more in favor of CABG and a strong p-value. So probably at least if we are preventing cardiovascular death, if not total death, and then these patients are less hospitalized, which may be important for some patients. I think it was one of the better studies in terms of and done in recent times for this category of patients. But importantly, for our discussion, if you look at the viability, in the cyst, there is a sub-study of almost 50% of the patients where viability was assessed. Here, the theory was that half of the patients, roughly, the myocardial viability was assessed, and then were randomized for medical treatment versus CABG. And you can see that the SPECT and the vitamin was used, echo. And almost you can see out of almost 1,200% of stitch, 600% were randomized for, not randomized for referred for viability assessment, and half of them are randomized to surgery versus medical therapy. And you can see the one thing is that like in previous trial, if a patient have viability, this person actually have better prognosis compared to the previous trial. But now because in 2000 we have better medical therapy. So with viability, they have better prognosis in terms of mortality. Also in terms of cardiovascular mortality, even though in multivariate analysis, the events was not significant, but certainly the numbers was less with present viable myocardium, which gives an additional prognostic importance. Similarly, if we add mortality plus hospitalizations, these are all in favor of viability, viable myocardium, they have a better prognosis. But most important is that if we randomize for viability or no viability, and then the mode of therapy, the surgery or medical treatment, there's hardly any difference. So if viability or no viability, if we send for surgery or if we do not send for surgery, the prognosis does not make any difference. So what is important is that, so whether do CABG or medical therapy, patients have LV ejection fraction less than 35, then actually viability testing is not useful on that aspect of improving prognosis, which was actually the initial hypothesis was actually not proven. So the stitch viability hypothesis, that if we assess viability, that are not useful in terms of giving a prognosis and to choose therapy. Although there are limitations of this study because the selection or referring patients for viability was not randomized. It was based on subjective criteria at the discretion of the operator. But certainly this is one of the better studies, larger studies to decide the relatively recent medical therapy in patients who have low ejection fractions. If not only the stitch, but we have also other few recent trial where we have seen this trial where PET scan was done and then were randomized depending on the PET scan or standard of care without PET, which is the things we are doing at least in our clinical practice, not sending for PET. So PET or versus no PET and then standard of care, there hardly any difference. Again, if you see the heart failure reduction trial in 2011, patients with viable myocardium sent for medical therapy or viable myocardium, then angiogram followed by revascularizations. Actually, this trial was stopped prematurely because there's no benefit of revascularizations. So this gives an idea, probably you did not have good quality data to say that viability assessments may not have a effect in terms of choosing a therapy, whether they will be medical therapy or CVG will have additional advantages. Again, I think that is, limitation of assessment of myocardial viability, because in stitch trial, they have shown that those patients who have extensive left main disease, like extended like left main disease, three vessel disease, proximal LAD, lower EF less than 24%, high angiosolic volume. So these are the patients who actually do benefit from surgery. And one of the theories is that, like in previous trial, it's not always the myocardial recovery. It probably there are additional benefit of myocardial revascularization like CABG, because it may not be only because of improvement of myocardial function, but probably also some of the effect like future event reductions like microinfarctions and even electrical stability. So that gives an idea that probably viability assessments may be only one of the factors that has to be considered while assessing these kind of patients. So for us,
we are running behind time.
So
you can finish
half
your
a minute,
presentation.
yeah, the last presentation, that will be the last slide. So I think the important is that the complexities in clinical decision making, viability is one aspect, and beyond viability, you have to look at the symptoms, angina, the coronary anatomy, the age, mitral regurgitation, renal disease, and I think most important for us is that good quality medical therapy is indispensable. So we have better medical therapy that already been discussed. So last slide, obviously you have imaging modalities which can use depending on the availability, viability and prognosis. Yes, interaction is not a continuous, is not mutually exclusive. And certainly at least we have better medical therapy to offer in patients who have heart failure, low ejection fractions with multivessel disease. Thank you.
Thank you, Indra. I think that was very well presented, and the stitch trial did show that trying to assess myocardial viability in severe LV dysfunction is not that important. Rather, most patients would do well with revascularization with if they are having LV dysfunction. So that's an important message. And over to the chairpersons for some remarks if they have, if any. And otherwise, we can conclude the session. Nirmalda, Baido, Manor.
I think a very good presentation, and the basic message that you have got, it is you have to go for evaluation if required, and for that one you need not look for the viability. The clinical parts matter very much, and also maybe the echo will help us in that way. Thank you.
So if there are no more further remarks, then we can conclude this session, since we are more than half an hour behind, almost 45 minutes behind, and we have to accommodate our guest speakers also. So I hand over the mic to Farin, congratulate all the speakers for a wonderful job done, and thank the chairpersons, and hand over the mic to Farin. Thank you.